always very clear. So I'll introduce myself first. So hello, my name's Rob. I'm the lead chief exec for the West Yorkshire and Harrogate Health and Care Partnership, and I'm currently on secondment from Swift, where I'm the chief executive. So this is an agenda which is close to my heart, really, and I've had quite a long career in the health and care system, including as a national director of workforce, and I think being a chief exec in the NHS, being somebody interested in workforce strategy and policy, have come to lead me to believe something is always true, and that's that the health and care system is made of people, and that's often hidden in plain sight because we often talk about structures, we talk about services, we talk about policies, we talk about buildings or drugs or innovation, but we should always recognise that every one of the conversations that we have is really about people. And there are some real opportunities and challenges around our people at the moment. We're 18 months into a pandemic, which at the start of, I joked that, this isn't going to be a sprint, it's going to be a marathon. What I didn't realise, it was going to be a series of ultra marathons, and we didn't actually quite know when the end was going to come. But what we've actually proven over the last 18 months is that our people have been magnificent and resilient and adaptable, and they've been able to be magnificent, resilient and adaptable because of the context and because of the support that they've had. What we've also seen then is people flexing the roles that they play and ways of delivering service change. So I've always been a fan of saying, well, how do we create an opportunity for people to flourish in our system, which is made of people, and how do we do that in a way which gives them career aspirations and also flexibility of role? And this session today really is exploring, within mental health, learning disability, autism services, how are we thinking about new roles and flexible roles which give us opportunities for people to have more fulfilling work, to have more and different career aspirations, and ultimately to help people fulfill their potential and live well in their community, which is what we're all about. So I think the session today is really important, and it's going to be full of interesting things which will allow us to, I think, give those new roles to people and ultimately have a successful set of organisations in a successful system. So I hope you enjoy the sessions. I hope you learn a lot, and I hope that we can, accelerate the amount of new roles that we have across all of our systems. So, Darryl, is there anything else that you want me to say or anything else you need to know, or is that a good start?
That is absolutely spot on and sets the scene beautifully. Thank you very much, Rob. So we're lucky that we have some speakers now. Sonia, do you want to introduce yourself just so people know who you are, because you've been key in all of this?
Hi, I'm Sonia Robertshaw, so I'm the workforce lead across the Mental Health, Learning Disabilities and Autism programme. Sonia and I, when we were planning this, we wanted a really good range of speakers who were living these roles and people who also had some theoretical knowledge, and we've been really lucky in the spread of speakers that we've got. And our first speaker is talking about the role of multi-professional approved clinician, previously non-medical approved clinician, but I think it's a different title now. But if I could ask Alex Irvin to, you've got half an hour, Alex, if that's all right, and that will be including questions. Sonia will hold us to account for time, I'm sure, but welcome, and we look forward to your presentation.
Good afternoon, everybody. I've actually got Lynne Balsham with me as well, so we're kind of trying to do a double act here and split it between us, and we're coming at it from different angles. So I'll introduce myself first. My name's Alex Irvin. I'm currently a nurse consultant and approved clinician in clinical training, and I work in the dementia inpatient services, and I'll let Lynne introduce herself.
Thanks, Alex. I'm Lynne Balsham. I'm a nurse consultant and an approved clinician. I have been an approved clinician for coming up to 4 years now, and I also sit on the approvals panel for North East of England. So I have involvement with reviewing portfolios of applicants for approval, and I currently work within acute inpatient all-female service in Leeds.
So I've got the job to start off with giving you a little bit of background here to these roles. So some of you might be aware that in 2007 there were some changes to the Mental Health Act, which has included a major revision of statutory roles, looking at opportunities for a wider range of professionals to take the responsibility for certain aspects of assessment, care, treatment for those detained. So those of you that have been round long enough will remember the old responsible medical officer. Well, this was one of the big changes, and it was replaced by approved or responsible clinicians. This meant that roles and professions like psychologists, nurses, social workers or occupational therapists could be approved to become a named legally responsible clinician for a specific detained patient. They have to be deemed to possess the most appropriate expert to meet the patient's main assessment needs, and have had to have completed the appropriate training, which is outlined through a portfolio route, which the Department of Health document is really clear in, and that will be circulated to you after this session today. But also in line with the regional approval panel process, which Lynne referred to earlier, who are really good at giving clear guidance and support to get you through that process. So I'm conscious there's a lot of confusion and people get really confused about what is an AC and what is an RC. I'll try to keep it simple. It might still feel clear as mud. I think in the early days of me starting this process, it took me a long while to get my head around it, and there are still days when I question myself whether I've got it right. But essentially a responsible clinician is the approved clinician who has overall responsibility in terms of the Mental Health Act for a patient's care. And they have some really key decisions reserved only for them as an RC, which include things like renewing of detentions under Section 20, discharging from a detention, granting Section 17 leave, and also making applications for CTOs. Obviously, with that comes a lot of report writing, quite often for tribunals and managers' hearings also. So to go back, an approved clinician is a person approved by the Secretary of State for Justice for the purposes of the Mental Health Act. So essentially, you cannot be an RC without being an AC, and they sort of come in partnership. So the difference is when you are specifically allocated to a patient, you are the RC. And when you are not specifically allocated to the patient as an AC, you still have some duties and responsibilities that you're able to enact, which include things like holding powers, reviewing of seclusions, and something Lynne will come on to a little bit later, where you might have an RC who is not a prescriber. You may need an RC who is a prescriber to support that plan of care, and Lynne will cover that a little bit more from her practice details in a bit. I just want to, and I think Daryl mentioned it right at the very beginning, I just want to take the opportunity here to touch briefly on language. You will often hear things like these are non-medical ACs, and these are MPACs, which is another label we've been given recently, which is multi-professional ACs. Personally, I don't agree with these. Why should we be referred to in the context of something we are not? We should be shouting about what we are, and maintaining our professional identity whilst undertaking an additional responsibility of the ACRC role, which in itself is clearly defined by law. So that, for that very reason, although I am not approved and currently in training, I will be referring to myself as a nurse consultant and approved clinician. I will not be using any acronyms. or calling myself a non-medical approved clinician. So a little bit of data for you. Sorry, I haven't got any more up to date at the moment, but as of October 2019, there were only a total of 78 approved clinicians on the register that were from nursing, OT, social work or psychology backgrounds across England and Wales. Now, I know there's been a good few cohorts started since then. I think I'm one of 4, so that's 4 cohorts that are going through their processes at the moment. But the outcome of those who end up registering or sitting in posts, I guess we'll know the numbers in the next few years. There is increasing interest in these roles, and that's why you've got us here today from mental health care providers. Providers thinking about starting and seeing it as an opportunity to distribute leadership within their workforce, and also some mutings of potentially addressing shortages of consultant psychiatrists. Now, this is where I personally ask you to just stop and think. This role isn't, for me, it isn't about filling gaps. It isn't about finding a cheaper alternative to psychiatrists, which you often hear discussed. If you take this approach or thinking this way, you're not living the spirit of the Mental Health Act. And I urge you to revisit the Code of Practice, Chapter 36. If you go and have a read of that, in this chapter, it is really clear that the patient's RC is the available AC with the most appropriate expertise to meet the patient's main assessment and treatment needs. So this is about the right person doing the right job for the patient, and just to keep that really clear in mind. So this is about you as trusts thinking about where these roles would be beneficial to improve your patient care outcomes and experiences, and really thrashing that out to understand what your patient's needs are and which professions can support better. So I'm not naive enough to think that there's still a group of people out there that will see this as a cheap way of plugging gaps in the workforce. But I really ask you to really think about that and reflect on that and remind yourself what the code says. And just to back that up, there has been some research into the implementations of these roles. And Lynne and I didn't want to do a death by PowerPoint presentation, but I just want to read to you a quote from Dr. Jennifer Oates, who is a lecturer in mental health at King's College in London, who has been part of a study in the implementation of these roles. And her end statement at the end of her final report was, and I quote, "Taking on the role of a responsible clinician for a patient means an ultimate responsibility for their care and treatment while they are deprived of their liberty. The moral and legal weight of these roles cannot be underestimated. As such, it requires adequate peer and senior supervision and training, as well as organisational and commitment to shift the power balance between multi-professional teams. This is also a discussion to be had if the role is taken up more widely regarding appropriate remuneration and grading for the considerable increase in responsibility. While senior psychologists and nurses of the likes may welcome the opportunity to lead care teams and promote psychologically informed approaches, this should not be seen as a quick and cheap workforce solution." So I'm conscious of time. I'm just going to quickly go through some of the training elements for this role. And it's a journey I'm on right now. You will be circulated a lot of documents after this, which covers it all in detail. So if there are any questions from that, please do get in contact with us. But essentially, it is a portfolio route. You are learning on the job in practice, and that's why it's essential to have really good support and supervision operationally and clinically to implement these roles. It's a big commitment for the person, but it's also a big commitment for the trust to support somebody on this journey. So you have your portfolio route, which is takes you through the 8 competencies you're required to evidence to seek approval. and the local approvals panel, which ours is NEAP, support in this process of reviewing those portfolios and making the decision whether somebody meets those competencies to be approved to carry out that role. On average, you tend to hear and get from people that it takes about 18 months to 2 years, sometimes longer, for people to go through that process. But one of the things that I found most beneficial was being able to undertake the postgraduate certificate in professional practice in law for mental health at Northumbria University. Personally, I think I would have really struggled just being supported in clinical practice alone to be able to get me through my portfolio to achieve that. I know medics aren't required to do that course, but I would urge anybody to take that course on. It really gave me a solid foundation in the law, the principles of law, and understanding how law is developed and applied. And I think it's essential for anybody on this process. Support for trainees is really important in practice. You need to have a mentor, and trainees must engage in learning sets throughout their training, but also after being approved. Now, given the greater number of ACs in practice are medics, it's highly likely that somebody who is a nurse, for example, who is going through this process is going to have a mentor who is a medic. There may be some work to do within your trust to win over hearts and minds with this. Some of my colleagues on my cohort have really struggled with being accepted in undertaking this training. And not really being supported by medical colleagues who don't essentially believe in the role, even though the law states that we are able to do it and the provisions are there to support us to carry it out. So that might be something to think about as well. I would urge you to have a look at the NHS Health Education England document, and they've produced an implementation guide for this as well. And that will be circulated to you after this meeting. So I'm going to pass on to Lynne now. I know I've taken up a lot of time, and she's going to give you a little bit of experience from somebody who's been doing it.
Thanks, Alex. Can I just check with you, Sonia, what time we're due to finish our part? Is it past?
It's at 25 to.
Right, okay, because I am very conscious that when I was asked to have a think with you about kind of the implications and how we'd implemented the role and what my job looked like and some of the challenges and the benefits, I'd stripped it down to the complete bare bones. And then when I spoke about it to my daughter's paper mache fish here and timed myself, it was 50 minutes. And I'm conscious that I have now 5 in order to make space for questions. So I do wonder whether, because this is a topic where even 4 years into being approved, I'm still finding that within the trust, there's an enormous amount of questions and an enormous amount of confusion about the actual practicalities of what the role can and can't do, what it does and doesn't look like, what the benefits might be. So I do wonder, I'm more than happy to talk through my experiences and what my role is, but I wonder whether the time might be better suited to put into the floor for people to ask me questions. I don't know what everybody feels about that, because this does seem to generate an awful lot of discussion really and questions from people that are wanting to implement the roles.
I'm aware I've just put a different thing in the comments, Lynne, that it's really good to hear from you. But equally, I guess we could have a show of hands. Who wants to hear what Lynne's doing, just by show of hands? And put your hand up if you want to hear from Lynne rather than go straight to questions.
Cool. Oh, well, I'm having quite a validating experience here.
Yeah,
thank you, everyone.
okay. Thank you very much. Hands down, everybody.
Okay. Well, I'll try and do a bit of a whistle-stop tour then, and I suppose just if people do have questions and it isn't something that's covered in what I'm saying, please do get in touch. I think my email's attached to some of the things that are going to be sent out to everybody, so please do get in touch and we can talk. So I suppose I just wanted to build a little bit on, I think Alex mentioned about how there needs to be a service need at the start of the process of identifying people to develop into improved clinicians. And I suppose I wanted to share with you a little bit about what the service need was in my case. And what that was at the time was we had 2 inpatient female acute wards who were both managing risk very, very differently in response to the escalating risks of young women with personality disorders. We had one ward that was attempting to keep them safe with the use of restrictive practices, and another ward which was trying to manage risk more therapeutically and in a less restrictive way. And that led to a lot of service delivery issues because the polarised types of care that were being delivered was leading to a polarised perspective from the ladies that we were attempting to care for. And we were having people that were being assessed in the 136 suite in Alps and various other places who were agreeing to informal admission on one ward and not the other. It was very uncontained. There was no predictability for people, and risks in that client group overall were escalating quite considerably. So there was a feeling that in order to address that variation, it might be helpful to have an approved clinician who could span over both wards, have a small group of patients who you'd have responsible clinician responsibility for on each ward, and then those groups of people who were regularly accessing our service could have consistent care. The AC would have a broader understanding of what was happening for them, of their formulation, of their needs, and be able to respond in a much more consistent way. So that was what the need was from our service. And I started the course that Alex has just completed in 2015 and ultimately gained approval from NEAP in early 2018. I fulfilled the post as it was intended, which was fantastic for a couple of years, and then COVID hit, and obviously the movement of staff around wards was then stopped. One of our inpatient wards was cohorted into a hot ward, and I was then moved substantively onto one single ward, which actually on reflection has really enabled the true benefits, I think, of the nursing AC consultant post to really come into flourishing. I mean, the leadership is much more robust and much more able to work with people in a very consistent way on that ward. So it's actually turned into a bit of a crisitunity, as my line manager says. It's actually been a really positive experience. So how my role is currently is the ward that I work on is a 22-bedded inpatient working age adult ward, which is very big in comparison to a lot of the other trusts that we work alongside. And I actually hold RC responsibility for 11 of those patients, and the consultant psychiatrist who also works within the MDT on that ward holds RC responsibility for the other 11. Just building slightly on what Alex was saying about how some of the AC responsibilities come into play when you're not functioning as somebody's RC. For reasons that I won't go into, but Alex touched on a little bit about maintaining your identity and not becoming a cheap doctor. I didn't do my prescribing before I became an approved clinician, but then latterly was encouraged to do so. So I ended up being a prescriber after I became an approved clinician. So my journey into prescribing is, well, I'm still on a journey, put it that way. So I still have an AC in charge of treatment for the people that I'm RC for. So how this works in practice is, as an RC, you have overall responsibility for somebody's care. You then, as a non-prescriber, if you're working with people who are prescribed medication as part of their treatment, you need to have an approved clinician who is a prescriber who can fulfill the legal responsibilities associated with prescribing medicines for somebody who is detained under the Act. So that always has to be an approved clinician, and usually that will mean that the prescriber is a consultant psychiatrist. Now, from an inpatient perspective, that dynamic is relatively easily managed because we have regular weekly MDT reviews. The communication is really, really good because we work on a ward together all the time. But it is stipulated within the code of practice that if you do have that relationship between clinicians working with somebody, that there are care plans in place that stipulate the communication between the two clinicians that are working with the patient, and also that the reviews, the timeliness of the reviews is agreed. So, for example, if you're in the community, the RC might review somebody on a monthly basis, but it might only need to be necessary for the AC in charge of treatment to see that person every few months if they're stable on their medication. But that must be agreed and stipulated within a plan of care. The other thing that's really, really important to recognise about that relationship is even if you're not a prescriber and you have an AC in charge of treatment who fulfills all of the legal requirements around Section 58, consent to treatment and all of those aspects, as an RC, you're still accountable for the overall care of that person. So any changes, starts, stops, increases, decreases to medication must be discussed with the RC prior to them happening. So there really needs to be a really good relationship and a really good co-understanding of what somebody's needs are. Now, one of the things that I was going to dip into with challenges, and Alex again mentioned, is that there is a very mixed response from medical practitioners about these roles, about the validity of them, and also about the ability of non-medical staff to fulfill the roles, and credibility can be a massive issue. So if you are a non-medical, non-prescribing responsible clinician and you have a very, very experienced consultant psychiatrist who isn't necessarily completely in agreement with a non-medical approved clinician, you're going to have to work that out, otherwise patient care is going to be compromised quite quickly. Personally, I'm really lucky because the consultant psychiatrist that I work with, we have a great relationship and we really share the same value set, which is really, really helpful. But like I say, your policies and procedures really have to be there to support working collaboratively if you're going to have that dynamic. That leads me on very nicely into, again, some of the challenges that have come up. Again, there's many benefits, there's many challenges, there often is to new roles. But one of the things that I've found is that even 4 years on, there's lots and lots of people that don't really fully understand what the job is, what you can do, what you can't do. And I think regardless of the amount of meetings that you go to, the amount of people that you share this with, we have such a transient workforce that you're always going to have that until it's embedded in culture. And that's likely to be 50 years down the line. So we often don't necessarily think about the poor FY1 junior doctor who's there in the middle of the night and they see a consultant nurse documentation and they don't understand that you're the RC and that you're directing this person's care. And if you're thinking about really high risk service users with personality disorder who we're saying if they tie a ligature around the neck and they want to discharge themselves, they can. That's a big call for them to make if they think that you're not accountable for that decision. So it's really important that the policies, the procedures, the governance structures, the infrastructure are absolutely abundantly clear so that everybody, irrespective of grade, stature, involvement, can refer to something to support them in understanding what your role is in somebody's care. I suppose a bit of an example of this is that we thought that we'd gone through everything with a fine-tooth comb before I started practicing. We had all of our, how you choose who's going to be the responsible clinician. We had everything gone through. And then I started practice and realised that although I could discharge somebody from section, I couldn't actually change their observations because it spoke about the consultant psychiatrist. So we kind of had a bit of a panic on and got that changed. But it's these little things that pop up that you're not really expecting that really throw a spanner in the work if you're not prepared for them. Right, we're at past. One of the other things that I just wanted to say as well, in terms of the mixed response from medical staff, I do want to say that it is a mixed response. So recently, I have had a consultant psychiatrist from the community contact me directly and ask for my involvement in somebody's care because the community team was struggling with their formulation, which was amazing. That's happened on a few occasions. On other occasions, I will have a consultant psychiatrist completely sideline me and contact the consultant psychiatrist on the ward instead, even though they're not even involved in that patient's care. So it is very varied. If it's something that you're thinking about starting within your trust, one thing that I've noticed in another trust that I visited when I was starting to train, which I thought was amazing, was that they did actually have it stipulated in approved clinicians' job plans and job descriptions that they had to support the development of approved clinicians irrespective of their discipline, and that was actually a stipulation within their contract, which I thought was absolutely amazing. So that might be something to consider going forward for trusts that are wanting to take this work forward. I will stop. I just wanted to say very, very quickly, I've scrubbed out half of the things that I wanted to talk about, but I was given a letter recently from a lady, which I think really sums up. I mean, I've got, evaluation data from nurses that I was going to share with you about the impact on their practice, and I can share that with you another time if people are interested. But this was from a lady who has a personality disorder. She's in her 50s and she's been in mental health care since she was 18 and dipped in and out of all sorts. She's been in PICU, she's been in long-term care, she's been all over the place. And I worked with her recently and she wrote me a letter which for me sums up the core therapeutic nature of nursing skills and what our core business is as nurses and how that can be translated into the relationship that you have with somebody as a responsible clinician. She said, "I've never met anyone in charge like you." When I first read that, I thought, oh God, where's she going with this? She said, "I've never met anyone in charge like you. You are so approachable and down to earth. I felt it so easy to open up and you listened to every word I said. I've never been listened to like this before, and you gave me the confidence to make my own decisions, decide what I wanted out of my life, and you guided me down the right path. You helped me so much and recognise that there's more to me than my self-harm." And to me, I thought that, when you think about the core skills of nurses and like say how that then translates into this sort of role, that to me just summed it up entirely. So I just wanted to leave it at that. And I'm sorry I've taken up a lot of time. There's loads else that I wanted to talk to you about, but do get in touch if you've got any specific questions.
I am confident that for all of our topics, we could spend the afternoon on them individually. So that was really inspiring. Thank you very much to Lynne and Alex for that.
Thank
really
you.
Clear and validating, I think, affirmation around the value of the role and also the importance of preparation. So very, very helpful. So I would invite people to put any comments or questions in the chat for Alex and Lynne to ponder, or I'm sure we'll be able to think about that around. I'm sure your contact details will be available in some of the things that we share, although you might be nervous now I've said that, but I'm sure you don't get enough emails. We'll make sure you get some more, but a huge thank you. And it's the first time I found the code of practice making me feel warm. So that was really good to hear. I'm aware of time, so Sonia, shall I just keep moving on now? Does that sound reasonable to you? Keep us on track. We're doing all right so far. Thank you so much. So our next topic is physician associate, and we have a range of good people who are coming to talk to us about this. So instead of me trying to introduce each one in turn, I will hand over and invite each person to introduce themselves, and thank you very much for being here. I can hand over now.
Hi, my name's Ellie. I'm a physician associate working at Sheffield Health and Social Care, and I also work as part of Health Education England as a physician associate ambassador. Myself and two of my colleagues are going to talk about physician associates. I'm going to just talk about generally what PAs are and what we can do. And then Pranav's going to talk more of the national picture, and Gloria is going to talk about specifically her role within mental health. Next slide, please. Is it frozen? Thank you. You can move on again, thank you. So I'm not sure what people's prior knowledge is about physician associates. So I'm just going to talk about the basics of who we are and what we can do, and then we'll go on to specifically within mental health. Next slide, please. So this is the definition of physician associate from the Faculty of Physician Associates. We are medically trained generalist healthcare professionals. We work alongside doctors to provide medical care, and we are a part of a multidisciplinary team. So the fact that we're medically trained is something that's really important to us. Most physician associate courses are part of a medical school. It's a 2-year course. We're trained to the medical model. This is really important to us, and we're generalists, so we don't specialise like doctors go on to. We remain generalists throughout our career, so we learn all areas of medicine, and we have to keep that knowledge throughout. This is done by the Faculty of Physician Associates, do an exam every 6 years, which is to check we remain with our general knowledge throughout. So we can move around all different specialities. Myself, I've spent 2.5 years in acute medicine, and then I've recently moved into psychiatry. So we can work in all different areas, and that brings a lot of benefits with it, different experiences. And we provide medical care alongside doctors. It's important to note that we are dependent practitioners, so we have to work under a dedicated medical supervisor, which is normally a consultant, and it's really important to build that relationship with them in order for the role to work. Then we can become more autonomous as we become more experienced, and we build that relationship with the consultant that we're working alongside. PAs themselves were introduced into the UK in 2013. It was a pilot scheme where they brought over PAs from America. It's a role that's been in America since the 60s, so it's very successful and experienced over there. And then after a couple of years, they found that it had an impact on physician and patient experiences, and they formed the UK Association of PAs, which was the first professional body, and then this is now the Faculty of Physician Associates, which has a managed voluntary register that it's recommended that all PAs should be on. And so if you are thinking of employing PAs, it's really important that you make sure they're on the managed voluntary register, as this is the only way of knowing that they've actually passed the national exam. Within our region, the University of Leeds started the course in 2015, and the University of Sheffield started in 2016, so it's still fairly new, and we are trying to push more PAs being employed within our region, in all areas, especially in mental health. Next slide, please, Sonia. So to become a PA, you have to have done an undergraduate degree. It has to have been in a science degree. So everybody's done a science degree beforehand. Usually it's biomedicine or biochemistry. Myself was actually psychology that I did as my undergrad. And it's highly recommended that you should have had healthcare experience before, whether it's volunteering or working as a support worker or something in healthcare beforehand. Then the course is a 2-year postgraduate diploma or a master's, so it was a diploma, and now a lot of universities have changed it into a master's. It's an intense 2 years. It was a very tough course. At the University of Sheffield, we did a year of mainly lectures and studying the basics of medical sciences and pharmacology, and lots of talks on clinical reasoning as well. And then our second year was all placement based, so you have to do at least 1,400 hours of placement, and this is across all specialities. There is only a 3-week mental health placement, which doesn't sound like very much at all, and it wasn't. But there was 12 weeks of general practice in there as well, and obviously there was a lot of mental health elements to that. In the mental health placement, we went around lots of different specialities within psychiatry, and I think this is when the Sheffield Health and Social Care initially saw what PAs could bring to their trust, and then later employed some of the PAs that had been on placement there. At the university, you have to do a written exam, which is single best answers, and an OSCE. So this is based on the medical model, 14 stations, history taking, examinations, emergency stations, and clinical reasoning. And then all PAs should do the national exam, which is run by the faculty, which is again a written and a practical exam. And all PAs should pass this exam before they can practice. Next slide, please. So PAs can take medical and psychiatric histories, do all ranges of physical examinations. We're trained to do diagnostic procedures, so clinical skills such as bloods, cannulas, ABGs, ECGs, a whole range of clinical skills. We can give depots, and we formulate differential diagnosis and management plans. To begin with, it's normally done along with consultant support until you become more experienced. And we can interpret scans and examinations. We're also involved in educating medical students and PA students, nurses on the wards. That picture is a picture of me and some colleagues doing some training for the students on basic life support. And that's something that a lot of PAs really enjoy. You can also get into different leadership roles. So like I work for health education 1 day a week, trying to get into different leadership roles, and this will come with experience as well, I think. And we can't currently prescribe or request ionizing radiation, so requesting X-rays or CT scans. It sounds like it's a big obstacle, but it's not actually become as much of a problem as people think. It's important, like I say, to have that relationship with your consultant or your medical colleagues and discussing cases, and then they can prescribe if it's agreed that they should be on that medication. I work in the learning disability team at the moment. In my role, I have my own clinics. I do medication reviews and psychiatric reviews of patients, and I also work on the ward a couple of days a week. So it's inpatient learning disability ward. On the ward, we act almost like a GP for the ward. So any physical health complaints, I would be the person reviewing them and then recommending prescriptions for these patients. And with my clinics, I tend to discuss it with a consultant, and then we come up with a plan together. And as my relationship's built with them, they trust me more with my decisions, and there's sort of less discussion had. Next slide, please. So I'm conscious I'm going on a bit. So it is still a new role. As I say, it's only been in our region for 6 years, so it's still very new. The census that the faculty did last year said that there was nearly 2,000 PAs. Only 2% of them work in psychiatry, so it's still very small numbers. But Health Education England have set a target that 10% of PAs should be working within psychiatry over the next 5 years. So it's really important to target as much as we can. PAs are employed on a band 7 on the agenda for change. Some trusts in the first year do a preceptorship role where PAs might be rotating around different areas, and this can be paid at a band 6, and they have like more supervision. And there is an apprenticeship role that's coming in, that Health Education England are looking into at the moment. Most PAs do work in secondary care, but 30% are working in primary care, and these numbers are growing again and again because Health Education England are providing extra funding for primary care roles. But I think it's really important just to highlight that there are hardly any in psychiatry, so it's all a learning curve. And I think a lot of the challenges that Alex and Lynne described are the same challenges that we're facing, of lack of understanding. But most of the time when people have worked with us, they see the benefits, and they really appreciate what we do. And we bring a lot of support to the junior doctor team, who have what can be a ridiculous workload at times, and they've realised that we're not stealing their jobs. And we are actually just sharing the job and sharing the roles, and it means that they have less to do and can actually leave on time. So once they actually work with us, they see the true benefits. Next slide, please. These are just some comments from consultant and managers that I've worked with previously, just highlighting that we brought positive patient care, and it's the continuity of care of having a permanent member of staff on the ward. We don't rotate like junior doctors do, so we can build those relationships with other staff members on the wards, and we can build those relationships with patients, and it really helps with continuity of care and patient experience. And just highlighting again that we reduced exception reporting from junior doctors because we were just helping them with their workload. And then the manager just highlighting that if you are thinking of employing PAs, it's really important to have a structure in place and have everyone on board and make sure that our roles are clear, our role and responsibilities are clearly defined within the team. I think I'll press on to Pranav now. Thank you.
Hi, thanks, Ellie. So, hi, my name's Pranav. I am an ST6 here in Sheffield, but I'm also a Health Education England Leadership Fellow, and my project is on physician associates in mental health. I've been involved in the PA project here in Sheffield since its inception in 2018, and now I'm sort of working with HEE more on the national picture. To try and get as many PAs as possible working in mental health. And what we have at the minute, the initial sort of strategy was to try and encourage PAs to come into mental health. That worked really, really well. And now we have loads of PAs interested in working in mental health and not enough trusts looking to employ PAs. And so now my focus, along with HEE and the Royal College, is to try and flip that around and redress that balance. Next slide, please. So why are we looking at bringing another discipline into our already quite diverse multidisciplinary teams? Well, Health Education England stepping forward to 2020-2021 workforce plan was looking at 5,000 new roles within mental health, and that includes physician associates. And in the mental health implementation plan from 2019-20 to 23-24, there was a target of roughly 140 PAs in mental health, and that's in addition to the PAs included within the 5,000 new roles in mental health. So there's a real push from Health Education England to get new roles within our MDT, and physician associates are a massive part of that. Next slide, please. Another big thing that we need to be looking at within mental health is the physical health aspects of our patients. As many of us know, serious mental illness, those with serious mental illness have an increased risk of physical health problems. With a 15 to 20 year lower life expectancy and a 3 to 4 times higher mortality rate. And of course, physical health issues are also extremely prevalent amongst eating disorders, personality disorders, depression and anxiety. And physician associates with their generalist training are really well placed to support mental health MDTs with managing physical health as well as getting involved with mental health, and they can also they're very well placed to advocate for mental health, for physical health for our service users. They're able to liaise with primary care and other specialist services in secondary care. They're able to encourage our service users to access physical health support, and they're able obviously to assess people both acutely and for chronic illnesses, so that they're a really useful resource within a multidisciplinary team. Next slide, please. So as I've sort of already mentioned, what we know about physical health in SMI is that it's mainly caused by cardiovascular disease, endocrine disorders, and respiratory disease. And the disparities are caused by, yes, our psychotropic medication, lifestyle choices, socioeconomic factors, and difficulty accessing mainstream services. Next slide, please. And as I mentioned, the training that physician associates receive and the skill set that they have make them sort of perfect for supporting our MDTs in managing physical health problems and supporting service users in accessing the care that they need, and therefore providing a much more holistic package for service users. Next slide, please. As mentioned, there's a big push both from the Royal College of Psychiatrists and Health Education England to get physician associates into mental health, and so there are quite a few resources out there as well. So I've put those links there. But the Physician Associates Working in Mental Health Toolkit has a vast amount of information on who physician associates are, or what physician associates are, what they can do in a mental health MDT. There are some sample job descriptions within there, and I'm currently working on updating that toolkit, but it is available in its current form and is very informative for anyone looking to employ physician associates. And the Royal College have a specific page on their website, or sort of several pages on their website, all about physician associates, which have loads of information, including videos and testimonies and various other things. So if you are interested, I would encourage you to take a look at that. Next slide, please. And, you know, the national picture is that there is a gradual rise in physician associates working in mental health. The Royal College estimate that there are roughly 80 physician associates working in mental health in England and Wales, and that number is going up. We don't have the figures for Scotland or Northern Ireland, but there are inevitably going to be PAs working in mental health in those regions as well. And as I've mentioned, there is a big push to ensure that there are more and more PAs working in mental health and supporting our MDTs. Next slide, please. So as I've said, there are resources there explaining how to employ a PA and how to go about it. But as Ellie's mentioned, generally when they come straight from university, there is a 1-year sort of preceptorship or inceptorship, and often they're employed at a band 6 level, and that's a year to really support bridging that gap between coming straight from university and working within a mental health setting. Subsequent years are then at a band 7. There's the Physician Associate Managed Voluntary Register, which we as a trust encourage, insist that our PAs sign up to, and most PAs do, and that's run by the Royal College of Physicians. There is a portfolio that PAs use, and that again is run by the Royal College of Physicians, and they're required to do 50 hours of CPD per year. And as Ellie has mentioned, they're also required to retake this, or to take their recertification exam every 6 years, though there are changes coming in when regulation is brought in by the GMC, hopefully next year. Next slide, please. So ongoing work nationally. So as mentioned, the GMC will be taking over regulation of physician associates. That was supposed to be this year. It's looking like it's going to be at some point next year. When that happens, there would be scope then for PAs to become prescribers. In theory, PAs leave university prescribing ready, so they've had a lot of the training, but I think logistically that there will likely have to be some sort of training or competencies designed to ensure that they can safely prescribe once the regulation has come in. But what it does mean is that they are able to support MDTs with prescribing decisions, even if they aren't able to sign those off themselves just yet. The National Collaborating Centre in Mental Health are developing a competency framework for physician associates working in mental health, and that should be available early next year. So we're looking at March next year. And that will help to sort of standardise what we would expect a physician associate to know and do within a mental health MDT. The Royal College of Psychiatrists and Health Education England are developing an inceptorship programme, which is very much based on the one that we run here in Sheffield, which is a sort of 1-year educational programme, again, to try and support physician associates working for the first time in a mental health trust and integrate them into a mental health MDT. And the Royal College of Psychiatrists are looking to develop their educational resources for PAs, as well as a membership scheme for PAs working in mental health or interested in mental health. Next slide, please. So I'm going to hand over to Gloria now, who'll give you a bit more of a picture of her experience in Sheffield. Thank you.
Thanks, Pranav. Hello, everybody. My name is Gloria. I'm also a physician associate, and I'm also a HEE Regional PA Ambassador here in Sheffield. Currently, I'm working on the older adult ward on Dovedale. Can I have the next slide, please? Okay. So just speaking a little bit about my journey and then going into what I do kind of on a day-to-day basis. I started off with an undergraduate degree in biomedical science here in Sheffield as well, and then went on to do the 2-year postgraduate diploma in physician associate studies, like Ellie said, covering all the basic areas within medicine. Just commenting on the time that I spent doing mental health as part of our placement, I elected to do some extra time, an extra 3 weeks within mental health, which gave a lot more insight into where it is I felt that I could fit in. And it was around about the same time that the Sheffield Trust was thinking about implementing PAs within the trust as well. So it kind of gave us both a chance to see where it was that we were going to fit in the extra 3 weeks that I was given to spend time there on both the inpatient and in the community areas as well. And then it landed with me being given a place on the inpatient ward. So like everybody else, I did my national exam. Luckily by then Sheffield were offering places within the trust, and I was given one. And I was started on a 2-year preceptorship course. Luckily, mine was started on a band 7. And during this preceptorship years, I was given a lot of teaching, which covered a range of topics within mental health, gave me a lot more confidence to go and do the things that were required of me. And also gave a lot of enhanced support in the way of supervision, space and time to speak with my colleagues or speak with consultants or people like Pranav who were had been in the trust before me, and would be able to give me more support along that line as well. That support, as my confidence and my ability has gone down, but still available for me there whenever I need it. And the next slide, please. So day to day, I split my time between clinical work and meetings. You can see they're quite varied across the days. I spend a lot of time with the junior doctors and the consultant, and also more recently with our ACP as well, who is joining the team and is training at the moment. Clinically, what I do is kind of deal with any new admissions that may be coming onto the ward, which is usually followed up by a senior colleague, usually a specialty doctor and above, more likely the consultant, where I may be doing some initial psychiatric assessments, making some initial recommendations about what to do. Involved with that as well, doing physical examinations on the patients, assessing bodily systems, dealing with any acute kind of physical illnesses that may be cropping up. And as Pranav touched on earlier, because the patients that we deal with have a very poor standard when it comes to their physical health in the long run. We have a focus on chronic illness as well, making sure that any ongoing monitoring that needs to be done through that is being completed. Any referrals that need to be made to appropriate services are being made too. Also trained, we have been trained to recognise and deal with psychiatric and medical emergencies, transferring them on to emergency services if need be. I also take part within the MDT meetings where I contribute to there as well. I do weekly mental state examinations on the patients there who are on the ward and contribute to that as well. I also have been, through the time, have been able to get started with working up people for ECT treatment, writing up tribunal reports when there's a need, working on SOAD requests as well. And that's kind of gone on as I have been here through the years, which is almost, well, it'll be 3 years next month, actually. May I have the next slide, please? Obviously, there are some limitations. Ellie touched on some of this earlier as well. We can't sign prescriptions. We can make recommendations for what can be prescribed to patients. And like Ellie said as well, it's never really been a problem for us to get prescriptions signed. As confidence has grown in us, what we say and just explaining what our rationale for prescriptions, they're usually given the go-ahead without much pushback from our medical colleagues. We can't order x-rays, but again, it's easy enough for us to rationalise why it's needed and for our medical colleagues to just give the go-ahead on them. We don't undertake seclusion reviews right now in place of the doctors. We can't detain patients under the Mental Health Acts. We don't have kind of like the 5-2 or 5-4 powers that the nurses and doctors have. And I can't deliver ECT, but I can help with working patients up for them and supporting them through that process. Have the next slide, please. Some extra bits that I do as I've kind of grown within the role is I often sit on the interview panel, for physician associates. We've grown quite a lot over the years. So it started at 2 and now we're at 11, I believe, covering a range of different places within the trust, inpatient community services, LD like Ellie is in, and they're looking to expand that in the coming future as well. And it's encouraging to see that the faculty is trying to encourage a lot more PAs within mental health and trying to raise that 2% to 10%. I also I get involved with the governance meetings, teaching as well, which is kind of like an area of which that I'm interested in, which is why I've pursued that. And also I've added the ambassador role onto my growing list of things that I do since last year as well, which is involved with me doing things like this, which is just advocating and telling people about the role and trying to encourage other trusts to take on kind of people like me, because, you know, as we'll come on to see, that PAs are very useful and very helpful within the MDT. Now, the next slide, please. I have 1 minute left, so I won't be too long. So just looking at the other thing, so we're given a lot of supervision through the consultants. They're giving us support with the CPD. We have a lot of teaching that is available to each one of us when it is available. And we're also using the electronic L2P process to get our appraisals done once a year. Next slide, please. And generally what people say, from patients to people within the MDT to doctors that we work closely with, is that we're a great complement to the team. We provide a great continuity of service because we don't move around every 4 or 6 months, that we are a face that the patients may sometimes recognize, but also kind of like a medical person within the team that the team recognize and can come to with any questions that they have. So I'm conscious of time, so I'm going to stop there. If anybody has any questions that you want to give to either myself, Pranav, or Ellie.
I am so impressed with timekeeping with our afternoon so far. Thank you so much to Gloria, Pranav and Ellie. Your comment, Gloria, was that you wanted to encourage us. I feel really encouraged by all that I've heard this afternoon, and I'm just, you know, doing lots of mental maths around our workforce as to how we can move forward with this, because it does sound really exciting. So thank you very much. Would it be at all possible for you to put your email addresses in the chat? That would be really helpful, and then we can deluge you with emails if that would be all right, in a supportive way. But huge thank you, all of you, for your presentation today. Sonia, we're moving on. So our next conversation is around the nursing associate role, and this is I believe Michelle and Chelsea, is that right? I can see Michelle and she's smiling, so that's really, and I can see Chelsea, so I'm really happy now. So thank you very much. If I can hand over to yourselves.
Yeah, that's fine. I'm just going to share my slides, so just bear with me. Right, can everybody see that slide there now? Yeah, great, excellent. Okay, so my name is Michelle Henderson. I'm workforce lead for nursing and midwifery within the North Eastern Yorkshire nursing midwifery and HP team. So I'm here today, delighted to be here today to really introduce you to the role of the nursing associate and tell you a little bit more about it and help me fit into mental health and learning disability settings. And I'm so pleased to be joined today by Chelsea, who is a nursing associate working within the region. So Chelsea will come in towards the end of this presentation. So the nursing associate role is pretty new compared to some of the roles that are out there, even compared to sort of physician associates. And it came from a document called the Shaping of Care Review in 2015, which recognised that there was possibly the possibility of a bridging role between healthcare support worker and registered nurse. Health Education England, which is my organisation, was nationally charged with getting this up and running as a brand new role, and started to pilot that in 2017. Nursing associate is a protected title in law, ensuring only those who have the appropriate qualifications should be using it. It is a registered role with the NMC, so that's the Nurse and Midwifery Council, and that's the same regulatory body that registered nurses and registered midwives, for example, also register with. So it's the nursing equivalent of the GMC, if you like. First nursing associates qualified and joined the NMC register in January 2019. So we're probably a couple of years in now to seeing the nursing associate role actually out there in practice. During the training, nursing associates are equipped with knowledge, skills and behaviours to enable them to support the delivery of nursing care across a wide range of health and care settings. And the training is very broad and general. So for anybody who knows anything about nursing, registered nurse training, you would normally choose a branch. So you would choose learning disability, mental health, child or adult. But with the nursing associate role, you don't. It's a general broad programme, and the individual, all the individuals on the programme cover the same topics, and it'll be tailored normally to the areas that the individuals are working, which we'll talk a bit later on about the apprenticeship side. Nursing associates will work within the code of conduct and within their scope of practice, just like a registered nurse or midwife would. And they would also develop their scope of practice and learning and development post-qualification, just like a registered nurse or registered midwife would. Now, in terms of what nursing associates do, they are involved in all processes associated with nursing care. And they work independently under both direct and indirect supervision of registered nurses, and also really contribute to that wider multidisciplinary team, working closely with other registered healthcare professionals. Now, the NMC do have quite a nice little chart on their website, which sort of gives the difference between a nursing associate and a registered nurse. And as you can see there, a lot of the things sort of have a crossover. So being an accountable professional, promoting health and preventing ill health. But you will see things that are sort of in sort of bold colours here, which sort of differentiate between the two. So the registered nurses, you can see, will very much have that leadership and that management responsibility. So an example being, if this was a ward type setting, the registered nurse would still be technically in charge of the shift, for example. And if there was a community or a clinic type setting, there would be a registered nurse around in case the nursing associate needed to ask any questions. So similar sort of set up to the physician associate, only in the nursing world, if you like. And really what the nursing associate role allows is for the nursing associate to sort of concentrate and provide that really hands-on care and working within their scope to allow the registered nurse to pick up those leadership roles and manage the more complex situations, if you like. So where do nursing associates work? Now, outside of mental health and learning disability, we have them working in lots of different places in health and social care. So, they are working out there in a whole range of specialities. But within mental health, learning disabilities and autism services, we have them working in the whole lists that you can see here, really contributing to care from sort of children through to adults through to older people. And in terms of outside of these realms, like I say, we have nursing associates working in other specialties, surgery, medicine, primary care, the social care sector, etc. So a little bit about how somebody becomes a nursing associate. So there is direct entry opportunities, which means somebody would apply through UCAS and do it as a programme that they'd self-fund. But those programmes are few and far between at the moment, although they are growing. But the main route is through an apprenticeship. So the programme is delivered as a 2-year apprenticeship, normally through a university. And as it is an apprenticeship, the person remains an employee and retains a salary whilst they are doing the programme, which is brilliant. They also gain a level 5 foundation degree qualification, which is excellent. So it really sets them on that pathway of academia. Now, in terms of entry requirements, they would normally have to have evidence of maths and English at A to C, GCSE, or level 4 for some of the newer people coming out of the system, or functional skills level 2. And usually must be able to commit to around about 30 hours per week, and that's in order to meet the NMC and apprenticeship requirements. During the programme, as I said, it's a very general, broad programme. And on cohorts, as I've mentioned, you will have people there, not just from mental health and learning disability settings, but from primary care, from acute trusts and beyond. So the cohort is a real rich learning opportunity. And because of that, trainees do get to see the whole scope and practice of across the lifespan, really. The programme is 2,300 hours, which is split between sort of learning in the base area, so your normal place of work, and also undertaking some alternative placement hours as well outside of their base area. Just to give an example in terms of pay, because I know we've talked about pay scales in some of the other roles today. So the trainee nursing associate is normally paid as a band 3, so that would be normally a support worker type level during their training, and once qualified would progress onto a band 4. And just to put that in perspective, a newly qualified registered nurse would normally come out as a band 5, and then obviously your band 6s and above are normally more experienced nurses or nurses with more specialist qualifications. Now, it is recognised that this is a guide only because, some mental health and learning disability employers may not be NHS, but this is just a guide in terms of what happens within the NHS in terms of salary scale. Employer commitment, as it's an apprenticeship, the individual would be eligible for off-the-job learning or study time, which usually equates to 1 day a week. They would need to be supported within their own base area with other nurses and other healthcare professionals to develop their skills. They'd need an NMC registrant who would act as an assessor during the 2-year programme to support that trainee and make sure that they're accessing learning and development opportunities and progressing through the programme. And they will need time to go off on external placements as well. A bit about fees and funding. We are quite lucky from a nursing associate perspective because it's one of the newer additions to the nursing family, and we have many national targets to grow our nursing workforce in general. Over the next few years, there is funding available. So first of all, I'll talk about the apprenticeship side. So because it's an apprenticeship, it is eligible to tap into the apprenticeship levy to fund the programme. So that's the cost of the actual university course. Now, I think predominantly everybody on the call today is maybe from NHS employers. So if that's the case, you would all be eligible to tap into your apprenticeship levies in your organisations to fund this. But also there's lots of support out there for smaller and medium organisations, and the government does have some set aside funds to pay for that. So course-wise, course fee-wise, it's quite good in terms of the fact that apprenticeship levy money has to be used by organisations. It's ring-fenced for that, so it's a really good opportunity to tap into some of that money from a fees perspective. There is some funding as well for employers from Health Education England, and basically there's 2 lots of funding. So within this financial year, anybody starting by the 31st of March 2022 can get £8,000 per TNA, and that will be £4,000 in year 1 and £4,000 in year 2 of the programme, and it can be used for a whole host of things. For smaller and medium organisations, they often might use it literally towards supporting that TNA in practice, but for larger organisations such as Trust, it often goes into the wider nurse and workforce development pot and system. There is a learning disability enhanced offer, and that is almost double that, which is £7,900 per year, which is £15,800 in total for employers. And this is for any trainee who's spending 50% of their time whilst on programme in the learning disability setting or with learning disability clients. And this is quite important. So, it doesn't just have to be a trainee that is working in what we would class traditionally as a learning disability setting. If employers rotate their trainees round, for example, and could get enough experience for trainees who aren't in a learning disability setting, they could still tap into this money if the time trainees were spending in those settings was 50% or more. So it's a really good incentive and contributes a little some way to the loss of your employee in your workforce. Benefits, NMC registrant, you are getting a registrant at the end of this, and all of that brings accountability, professionalism, and being held by a code of conduct. One of the great things about this role is it allows you to grow your own. So once the person is qualified as a nursing associate and on that NMC register, the nursing associate is a role within its own right and a really valuable role. But also people could then go on to top up to become a registered nurse, and that only takes 18 months. So in reality, if you've got really good support workers out there in the system, this is a really good career pathway for them and a really good career development opportunity for your support workers. And may I not just add, not just for support workers, but we've had receptionists, we've had phlebotomists, we've had a whole host of people who are working in sort of those periphery roles that are not such hand-on care, but really still have good sort of public forward-facing roles. So, really think about your staff you've got out there. If you've got somebody who really wants to develop and really wants to push into a clinical role, this is a great opportunity for them to do that. And like I say, you can have that really good career pathway there. So, you've got your healthcare support worker through to nursing associate, through to registered nurse, right the way up through to your ACP roles. So it's a brilliant opportunity. I couldn't forget to mention, so how people attract the nursing associate is we often find people recruit internally, so they grow in their own staff, which is absolutely brilliant. But there isn't anything to stop you advertising this apprenticeship opportunity out there to the public and attracting new staff into your organisation. And I think this is really sort of, if we think of this opportunity from a widening participation perspective and from a social mobility perspective, and really if we look at the agendas going forward in terms of how as an ICS, for example, we look to add to how do we develop our economies out there in our communities, and how does our workforce reflect the communities that we serve, this kind of role is absolutely brilliant for that, because what you're doing is you're allowing that community to have an opportunity to be paid, which is quite important. Not everybody can go back to university and be a student. They can get a salary while they're doing this role, and they can also work towards a level 5 qualification, which then opens the door for them in terms of further steps up into academia and further academic learning. So for me, I'm really passionate about this role, affording people the opportunity to develop who may never have thought that this was an option, may never have thought that an option for them to go to university, for example. So this role has a twofold benefit, I feel. Not only is it contributing to that nursing workforce and really sort of allowing the registered nurse to develop and work to their highest end of their scope of practice, it's really adding to those other agendas as well, which I think are going to be really, so important going forward. And as I've mentioned, it allows that RN to work on their more complex and leadership roles. who runs the programme in the West Yorkshire area. So we've got several universities at the moment. We've got the OU, we've got Leeds Beckett, Leeds Uni, Huddersfield, Bradford and Bolton, who deliver a programme into Bradford College. They basically use their premise, but it's a university programme. And those are the start dates for the next cohort. So plenty of choice within the region, plenty of cohorts, lots of support there out there in the universities for people who've never studied for a while, thinking about the kind of candidates that might come through this programme. Lots of support for the employers. Within Health Education England, we have a bi-monthly meeting which supports employers around all things to do with embedding the nurse and associate role into your practice areas. And we've just actually set up a sort of a sub-offshoot, if you like, where all of the trusts from across the region, so that's not just the West Yorkshire area, that's South Yorkshire, that's Humber Coast and Vale and the North East and North Cumbria, are all coming together from across the mental health organisations. So we've got Leeds York Partnership, we've got RDASH, we've got SWIFT, we've got Humber Teaching Hospitals, TUV and CNTW. So all our really big mental health and learning disability providers coming together to really sort of discuss where this role can go further and what kind of things are you sort of getting your NAs, your nurse and associates to do. So there's real support out there for employers who are a little bit uncertain if this role is for them and could fit into their service. Some information on the slides, just with some pointers to the NMC standards, and there's some really good case studies on there around the nurse and associate role, including mental health and learning disability services. Just my email address. I'm always happy to take calls or emails or anything from anybody who wants to find anything out at all about the nurse and associate role. Just ignore the name underneath. That's just for non-big employers who may need support with getting some money to pay for the programme. So I'm just going to stop sharing now so you can see my face. And what I'm going to do now is I'm just going to hand over to Chelsea for the last 5 minutes. And Chelsea works at Leeds and York Partnership and she's a nurse and associate there, and she's going to tell you about her journey.
Hi. Just to keep it brief, really, I know that we've had a lot on today. But as Michelle said, talking about my pathway into sort of the nursing associate role. So just a brief timeline, I've worked in Leeds and York Partnership for about 10 years and I was an administrator within IT. I wanted to sort of try the clinical role, and that was something that I'd had sort of experience as an unpaid carer with prior to starting. And I was lucky enough that we have a really fantastic volunteer team. So I got on with the voluntary services of Leeds and York Partnership in about 2015, just to get some sort of more hands-on experience with what it was like, I suppose, to work there, to see if that was right for me and to see if I was right for them. And I spent about 6 months in a community mental health team, sort of 1 day a week, supporting the team and the patients there. From then, I was able to get sort of the experience to go and apply for a bank support worker role, which I did in 2015, sort of towards the end of the year. And then I think it was a substantive role that I applied for to sort of get myself based within an acute mental health team, to sort of build up that knowledge within a specific team, because I was going around the trust and working in different departments. And that was in 2016. I think I spent 3 years on where I still am now at my acute mental health ward, working with a fantastic team and supporting some lovely patients. And that really made me motivated to do some sort of further training, and I had a bit of drive to do that. I'd seen the TNA course advertised, and I know a member of another team that I worked with had completed the pilot scheme, so I thought that looked like a really good opportunity to become a registered professional. Unfortunately, at that point, I didn't meet the entry requirements for the role, so I was lucky enough to be supported through the vocational learning team to sort of redo my maths and English, and the care certificate as well, which was really beneficial as part of my ongoing appraisal and development. That again was, I think, 2017 to 18 I'd completed those. within the trust. And then the opportunity come again to apply for the nursing associate role. So by that point in 2019, I was lucky enough to have met the requirements, I suppose, with the support of my team and the practice learning development team. And I was successful at gaining a post there. And I completed the course in May 2021 to become a registered nursing associate, which has been a fantastic experience for me personally and the wider team as well. That was something that I wouldn't have had the opportunity to do unless it was an apprenticeship where, like Michelle's touched on, not everybody's got that ability to sort of go be a full-time student, and particularly a mature student I'd be at that time, things get difficult, don't they? So since qualifying, a bit about my role really, I'm part of the preceptorship, so I've joined the preceptorship of, well, we have a wide preceptorship at Leeds and York Partnership. We have nursing colleagues, mental health nurses, occupational therapists, other associated health professionals. So I've joined their preceptorship course, which lasts about 6 to 12 months, depending. And I've been able to stay within my clinical team. So the ward I'm on at the moment, I've worked on since 2016, moving from a support worker to a trainee to a registered professional, which has been absolutely fantastic. So it's not, I suppose, it's a personal journey for me, but what I found is the way the team have responded, because it's not just sort of development for myself, I suppose it's encouragement for other nurse support workers that want to apply and are able to see the possibility to do that. But bringing that clinical knowledge to a team, and I think that's what we're focused on at Leeds and York particularly, to make sure that it is the benefit, at that local level. So I particularly work across the lead for physical health care within our mental health setting. So I've taken the lead for physical health, and there's some safe ward aspects that we've got. We've got a wide range of physical healthcare skills which are particularly beneficial. I think, is it the physician associate previously as well? So nursing associates continue to do ECGs, venipunctures, meds management, so depots and things like that, medication round on the ward, shift coordination and risk assessment. So sort of all the formal nursing assessments that we'd use under the supervision of the mental health nurse as a nurse in charge. I'm trying to think about, and we've got a very varied range of skill set that we use. So within the physical health section, we're heavily involved as well in the delivery of the bite-size training. So sort of supporting other colleagues, whatever their level, to refresh their knowledge and skills and honing in on that side of things. I didn't know if, if anybody had any questions about how it's sitting at the moment in the mental health setting.
Thank you. Are we able to, like with the other presenters, put questions into the chat or via email, Chelsea and Michelle? Would that be all right?
Yeah, that's fine.
I would just like to say we're 1 minute off. Do you have anything else that you want to use that final minute for?
Yeah, I would just like to add, Chelsea, you probably need to say what your next step is really, because I think this really sort of shows the growth of where you can take this role.
Yeah, so I've been lucky enough to have applied for the top up that Michelle touched on, which is an 18-month apprenticeship route to become a fully registered mental health nurse. So that's something that I'll start in January, and I think it's just a massive benefit to be able to see that progression, really, because it's not for everybody, to be honest. Not everybody wants to become a fully registered nurse, but that option is there for the people that do it. It's quite a mixed barrel from what I've seen across the cohorts, where you've got that opportunity to really zone in, because it's a generic course, in your specialist area, whether you work in children, mental health. So that'll be able to improve my knowledge and skills specifically for the trust and the base that I'm in.
I love how you say that you've been lucky enough rather than I have worked so hard and this is where I'm going to next. really, really good to hear. Thank you so much, both of you, for that. And I always think, speaking as somebody who didn't get the A-levels to go to uni, so I couldn't go to uni when I left. And when I became a nurse, it was 5 O-levels, I think, nearly 34 years ago. I don't know if I might be the only one who can remember that. That was my only way in. They wouldn't let me into university. So it's incredible. I'm really heartened that we have other ways in for people who don't get the grades that they need. Thank you so much, Chelsea and Michelle. Now I'm going to move us on smoothly to our final presentation, which is on advanced clinical practitioners. And I can see Lucy is there. And Lucy, do you have Kim with you as well?
Hi, yeah, unfortunately Kim can't make it today, so it's just myself, but I can see a few of my ACP colleagues online, so they can feel free to chip in.
You are amongst friends, or welcome. The floor is yours. Thank you.
Hi, so yeah, hi, it's nice to meet you all. I'm Lucy Hudson. I'm a trainee advanced clinical practitioner from Sheffield Health and Social Care. I work in learning disability services, and my colleague Kim was in mental health services, so it would have sort of hopefully represented, you know, both sides. So I'll do my best to represent both. Next slide, please. So I'm one of 14 other trainees in Sheffield Health and Social Care Trust. So there's trainee ACPs in acute inpatient, substance misuse, recovery, community mental health teams, older adult home treatment team, the home treatment team, SANS, early intervention team, and then myself, who's in the learning disability service. So I work across community and inpatient. And we have 3 new posts for perinatal, eating disorders, and memory services. Next slide, please. Yeah, so I think as you mentioned, Daryl, we could sort of spend, you know, all day talking about these roles individually. This is a real whistle-stop tour, but just sort of breaking it down to look initially at the Health Education England definition of an ACP. So this is covering all roles, not the mental health specific ones. So advanced clinical practice is delivered by experienced registered health and care practitioners. It's a level of practice characterised by a high degree of autonomy and complex decision making. It's underpinned by a master's level award or equivalent that encompasses the 4 pillars of clinical practice. So leadership and management, education and research, with demonstration of core capabilities and area specific clinical competence. And so next slide, please. And again, just there's a real emphasis here on working across services and working across sort of traditional pathways of care. So ACPs are part of the NHS long-term plan, an NHS people plan, central to helping transform service delivery, better meeting local health needs, as well as transforming and modernising pathways of care by, I won't go through them all. But again, like I said, sort of emphasising that leading on care, patient safety, working holistically and working across traditional pathways. Next slide, please. Yeah. So just to sort of put a little bit into context, ACPs are really well embedded in acute services. They were born from the 5-year forward plan. The NHS long-term plan highlighted ACPs being central to helping transform service delivery and better meet local health needs by providing enhanced capacity, capability, productivity and efficiency within MDTs. The role has sort of been widely promoted as being the solution to chronic understaffing in the healthcare system, and it mainly aimed to address medical workforce gaps and to improve patient safety, quality and effectiveness. Over the last decade, there's been a national skills shortage in the medical and non-medical workforce. So there was an aim to sort of really upskill the current workforce and sort of retain staff. And the ACP role offered a clinical route for progression for multi-professionals, whereas previously progression might have relied heavily on management roles. And as the role's progressing, there are new capability frameworks that are specific to practice areas. So there's frailty, orthopedic, there's a new mental health one, and a learning disability and autism one as well. Next slide, please. So just to highlight really that ACPs are multi-professional. It's not just nurses, although a large proportion of them are nurses. The amount of times we've been called an AMP when actually the training's very different. And yeah, this is sort of expanding. I believe dietitians are now added to this list, but yeah, pharmacists, OTs, physios, speech therapists, paramedics. And part of the training is quite interesting, really, because we all have something different to bring to the table. The paramedics are really hot on that patient assessment and picking up, red flags immediately, whereas, our skill set might be a little bit different. Next slide, please. So the 4 pillars of advancing practice, our roles really sort of have to fit around this. And 80% of our time should be clinical. I just wanted to highlight that, because I think with competing priorities in the workplace, often that can get whittled away. And again, just really emphasising that this is a clinical role and not a leadership or management role. And the leadership and management element of this is around sort of clinical cases and work. It's not around sort of service operational management. Education, so during training, obviously that's about your own development, but on qualification it's more focused on educating and upskilling others. And research, part of the course, the dissertation, is that you do undertake your own research, but for the future of the role, that can be different levels of engagement in research. It doesn't always mean that you're sort of the principal investigator or conducting your own research. Next slide, please. So the training itself, there's a master's course which is 3 years. There is now the apprenticeship option available, which is the same length of time, I believe. So assess through a portfolio and practice against the competency frameworks within 5 years. So as I mentioned earlier, there are the mental health specific ones and the learning disability and autism specific frameworks now, which we're assessed against. I've been assessed against both, which is okay actually. You can sort of pick the best of both, but make sure that I meet one of them fully. The training is 2 days per week commitment for 2 years, and then in your final year when you do your dissertation, it's 1 day a week. There's a requirement for placement hours. You have a designated educational supervisor and assessor. It's quite a big commitment from the workplace, which, I think it's important to sort of emphasise that, and also that, we're grateful for the opportunity. And as I mentioned, sort of national frameworks with practice area specific pathways are being developed. So as the role is sort of growing nationally, not just in mental health services, but you're now seeing jobs advertised for more specific ACPs. So for example, critical care ACPs, respiratory ACPs, and so on. Next slide, please. So the training itself, the first year is a sort of a core year that everyone does around advanced physical examination and consultation skills. And then if you're a registered profession that's able to train as a prescriber, then you would do your non-medical prescribing. But if you're not able to, then you would do pharmacology. Your second year is practice area specific modules. So for us, Sheffield Hallam University was one of the pilot areas for the mental health modules. I've been lucky enough to be funded for a year at Cumbria University to do the learning disability specific credentials. But these are sort of developing all the time, really. And I think Sheffield has quite a large choice of respiratory and cardio specific modules as well. And then your third year, which is your final year, is your research project and your dissertation. So sort of going on to the next slide, if that's okay. I think when we think about the ACP and mental health and learning disability services, it's quite useful to look at this Venn diagram. So it sort of puts the ACP really in a powerful position to be able to take the best from each profession and skill set that they have. And I think the difference with an ACP is that we do already have our own profession specific. So I've been a nurse, a learning disability nurse for 10 years. So drawing upon that experience with my new training to sort of, deliver something different really. And I think at the end I'll touch on that's one of the challenges, one of the opportunities, but also one of the challenges that, we are already very experienced clinicians in our specific roles, but we're quite novices at being an ACP, and that balance sometimes can be difficult to get right. So the only risk here is that the ACP can be used to fill gaps, and I'm just sort of echoing some of the conversations I think throughout previous presentations. The most obvious example here is an ACP that's a nurse by background being asked to cover the ward, which would be a Band 5 staff nurse role, and that can be quite frustrating at times, but it has potential to add that real sort of robustness and resilience to an MDT, and being able to clinically lead on care as well as use other professions more appropriately. So for example, ACPs leading on formulation frees up psychology to deliver, more psychology specific interventions. Next slide, please. So as I mentioned, sort of the role's really well embedded in acute services, but I think as I'm going through my ACP training, I'm realising more and more how the skill set of an ACP just goes hand in hand with mental health and learning disability services because of the client group, and the health inequalities and barriers to healthcare that they experience. And how, it's these clients that often ricochet around services, and the ACP has the opportunity really to lead on the care and deliver the whole package. So, I probably, with the audience here, probably don't need to go into those things that our client groups experience. Next slide, please. So we both just wanted to give you a quick snapshot of a case study that we had each. So Kim isn't here to sort of bring her case study to life, but just it was quite nice really how they complemented each other, because Kim works in inpatient services, hers was around a gentleman who had a really complex mental health presentation and trauma history, substance misuse, and subject to a lot of restrictive practices. And in essence, what Kim was wanting to share was how more restrictions that were placed on this gentleman led to the risk escalating and his mental health deteriorating. And it was a case that really required that robust leadership that she was able to deliver clinically, initiating the treatment plan, leading on the formulation, leading on the risk management plan, and leading the team through that trauma-informed care approach. Sadly, I can't bring Kim's case study to life as well as she can, but that was Kim's case study. And then if you could move on to the next slide. My case study is a lady a 45-year-old lady who had very complex behavioural presentation. She had severe learning disability, epilepsy, fluctuating mobility. It was her first placement away from a family home, and she was presenting as extremely distressed, significant self-injurious behaviour, and causing herself really serious facial injuries, high risk of hospital admission, and high risk of having a seizure because of the level of distress that she was in. And in my role as an ACP, I was there for absolutely ages. It's one of the things that I've learned. My assessments just seem to be getting longer and longer as my skill set grows. But in a 3-hour visit, I was able to undertake really comprehensive assessment of a physical health and mental health, as well as doing behavioural observations. And there and then we could put in place a positive behaviour support plan, streamline a medication, prescribe a PRN medication, request further investigations, and request a referral on to neurology. And when I think about what was different with this lady in terms of how I was working before, it really was around sort of being able to lead on the care, being able to deliver a much more advanced level of assessment of a physical health and a mental health, but then also act on those. Whereas previously I was putting together like a case to either subsequently make referrals to psychology, psychiatry, or ask for the GP to action things, where I was just able to do them myself. So the patient herself, you know, her needs were met much quicker. If we could go on to the next slide, please. So both case studies just sort of emphasised really the potential for the role and the value it could bring. So for the patient receiving a holistic assessment of the physical health, mental health and the behaviour, a dual approach to pharmacological and psychological interventions, treatments being provided quickly and was effective. It avoided service barriers, reduced waiting time, or for Kim's case study, it was reduced the length of stay in hospital wards, reduced restrictive interventions, and again, it sort of followed the patient throughout the whole journey. And then for the service, it was that ability to work across pathways of care and services, a cost and time saving for other professions, so for psychiatry, psychology, nursing and the GP, positive relationships with the GP and other professionals. It enabled role modelling to other staff and shared learning, improved responsiveness from the service and building that resilience in the system. And just that we're both sort of focusing on creating ACP-led clinics. I think in Sheffield they're actually trialling an ACP-led GP practice, which would be interesting to hear more about. So yeah, next slide please, that's okay. So risks and hurdles, I think most, you know, understanding of the role is what everyone said throughout the day. But I think it's the one thing really, we're really keen to sort of raise the profile of our role, and the lack of understanding of our role leads to inappropriate use of us and our skill set. And like I said, you know, quite often maybe being plugging gaps for nursing. I feel that we all feel that we really need an ACP specific lead for the trust, who's actually an ACP and able to sort of strategically lead on things for us. And all of that would help with the governance structures and the supervision structures. There's a real need to sort of evaluate the role. And as I mentioned, that sort of expert versus novice. The unique thing about an ACP is that they're, you know, they're very experienced clinicians already in a particular field, but then a novice at being an ACP. Next slide, please. In terms of opportunities, I think we can all sort of see really the vision of how this could work really, really well. There is, I believe there's been a development of a career progression framework up to nurse consultant, which now includes ACP as an integral part of that. Nationally, ACPs, as I said, are sort of very well embedded in acute services and primary care, but there aren't many ACPs in mental health and learning disability services. We're lucky to have been part of the pilot in Sheffield for the mental health modules, and myself in Cumbria for the learning disability modules, but having that community of practice nationally, I think would be really, really important. We're able to deliver the whole patient journey, which, you know, is really exciting. It improves that patient experience, reducing handovers of care where we know that things can often fall down. And yeah, it's an exciting time in terms of the development of competency frameworks. Last slide, please. Second to last slide. I guess just in summary, the role is still in its infancy. I think we have two of the 14 of us that are about to qualify, I believe, and hopefully, taking that role forward as we're all going through our training, the role will continue to embed. But without a doubt, we've all got our individual examples of where it's really making a huge difference for patients. And we feel that with improved governance and support structures, the role has a real potential to sort of revolutionise. I know that sounds really, really bold, but looking back at how I mentioned that the client group is the most likely to experience health inequalities and barriers to accessing healthcare, the ACP skill set sort of makes sense in terms of how it can address some of those for this client group and for our services. I think the next slide is just if there's any questions from anyone. I have put a reference list at the end, but it's a very reduced reference list, and we can provide a full reference list if needed, if anyone would like that.
Thank you so much, Lucy. I'm sure we would, if that's all right. And I would imagine we can share that out, Sonia, after today. Huge thank you for that, Lucy, and thank you for stepping in and doing two people's jobs this afternoon, but I guess that's not unfamiliar to you either. So we have a few moments, given that Kim wasn't here, so I guess I know some of our earlier speakers have left, but do we have any questions? I can see John's hand quickly up there.
Hi folks, sorry about that, just unmuting there. Yeah, Lucy, that was brilliant, and by the way, you represent Sheffield Hallam wonderfully, so that was fantastic. Yeah, it's just to say that I'm the academic delivery manager for the Advanced Practice Mental Health pathway at Sheffield Hallam, so I work with Angie, Lucy, on that, and yeah, people like Helen Jennings as well, who's moved to Ardash now and is really trying to establish the role in practice as well. And what we're finding is that's the real kind of hard work. I think Sheffield Health and Social Care are very much ahead of the game. You've got 14 trainees, so there's real kind of momentum there, which is fantastic. But we need to keep that going. And I just wanted to mention as well, we work very closely with Huddersfield University on this as well. They're also early adopters. So there's the two in our HEE region. We're the only one with 2 universities who are early adopters of the mental health advanced practice route. So there's no competition here between us and Huddersfield, and we're working really closely because we both want the capacity to be increased, and we want this really to build, because when I go to meetings to try to lead on this, sometimes it is a bit like talking a foreign language to people, Lucy. It's just not on the agenda at all, mental health advanced practice. So good luck to you, and but I think it's building, we're getting there, but this is a great idea whose time has come. It's long overdue, so thank you.
Sure, we'd all echo your words. Thank you very, very much for that, John. Do we have anybody else who has a question or a comment at this stage of the day? We have a few moments.
I think one of the things I just wanted to add is, we're all in SHSC, we're finding our feet really with how we work alongside the physician associates, because some of our skill sets are the same, but some of it's very, very different as well. The physician associates are already qualified and sort of hit the ground running, whereas we're still in training. And I think it's a real opportunity that we need to get right. I think for me, the difference is, it's not just around the prescribing and that sort of clinical set in stone thing. It's around the leadership and sort of that more autonomous working. But for me, I work with Ellie in Learning Disability Services, but sharing the skill set, but knowing what our differences are and each other's strengths is key. And I think we do on a local level, but it needs to be broader than that.
Yeah, we all have a place, don't we? It's just being clear as to how all that fits in. In the absence of any other hands, I might just take the opportunity to say thank you. I think it's been a really inspiring afternoon, just to help us all take a step back and think what can be possible. That's how I feel. I guess it's also there's a strong message about this. Isn't just about a response to perceived deficits in any workforce. This is about being very clear that these roles bring value, and there's a difference that brings additional value to our workforce and to the experience of our people who are in our care, and also in the way that colleagues will be worked with and supported. There's also been a persistent reminder that the head's connected to the body all the way through, hasn't there? That physical health has it's a significant inequality for people in our care. So whatever we can do to advance that feels really powerful. We have recorded this, Sonia, haven't we? So this will be available for a small fee. I think we can set, it's been good enough to charge for, hasn't it, Sonia? Don't you think?
Yeah, we have recorded it, so we will make it available afterwards, and we'll share all of the slides. But what we also want to do is follow up with a survey, which we'll send out. And what we want to get some feedback on is, would these events be useful in terms of covering any other roles, and what sort of other roles people would be interested in finding out about. So I'd really appreciate it if people could take time to complete that survey when we send it out.
And Sonia and I will listen and will be guided by you. So generally, I just want to say thank you very much for your time on a Friday afternoon. It's testament to the speakers that almost everybody who started on the call is still here. So thank you very, very much. That's really impressive for a Friday. Normally folk would have gone home by now. So thank you to everybody. Sonia, do you have anything else you want to say before we close?
Just to again say a huge thank you to all the speakers for coming today and everyone for attending.
And yeah, absolutely. And all the speakers, see all the lovely comments in the box when it comes around. You've got a lot of really, really lovely feedback. So thank you, everybody. And I wish you all a very, very good weekend. Thank you. Take care, everybody.
Thank
Bye-bye.
you. Bye.
Thank you.
Bye. Bye.